Hello, my name is Dr. Craig Chappell, and I would like to talk about hip pain today, specifically SI joint pain, which is very common in our area and generally more associated with females than males, although males can have it as well. So a lot of people will go to the physician or whatever practitioner they go to and will be diagnosed with sciatica. And so that really gets me fired up because sciatica is a radicular pain pattern which goes down the leg, but it's only 20% of pain patterns that go down the leg. The other 80% is called a sclerotomal referral pattern, which is secondary to connective tissue disorders. So specifically SI joint dysfunction. So I'll walk you through kind of how I diagnose SI joint dysfunction and the history associated with it. So this is generally a dysfunction in which a person will go to a practitioner, be manipulated, something will happen, they'll feel better for 3 days, and then their pain returns. That's because the SI joint is unstable. Some risk factors associated with SI joint dysfunction are being a female, having lots of babies, or even being pregnant. So other risk factors would be activity levels, so sports injuries, falls, anything that requires a shearing force through your pelvis. So when a patient comes into me, I ask them, can you point to your pain? And they generally point like this. This actually has a name, it's called Fortin finger sign. So when I see that, we know that, wow, this is probably a connective tissue dysfunction versus a radicular pain pattern. So SI joint dysfunction will also refer pain to the buttocks, down the leg, and sometimes all the way to the foot. So the next question I ask is, does it come and go? And generally it will come and go. It can be manipulated. It'll feel better for a few days, and then it will come right back to normal. So this pattern goes on and on. So they get to the diagnosis of functional back pain because most of these people have had an X-ray and an MRI, and it's relatively unremarkable, or they may have a couple bulging discs or even a disc herniation, which doesn't seem to fit the pattern for their pain syndrome. So in the office, we do a couple tests. I have the patient lie on their back. So we'll lay on your back, and the first thing we're going to do is ask them to do a straight leg raise. And so can you go ahead and raise your right leg off the table? Good. And we'll do the same thing and do the left leg off the table, and good. And what I'm watching for is how the pelvis rotates during this straight leg raise. So generally in the case of SI joint dysfunction, a patient will have a heavier leg. So it's a little bit harder to initiate the movement on one side versus the other side. And if that's the case, the next thing we'll do is fill the pelvis and add compression to the SI joint, and then go ahead and raise your right leg again. So we'll pretend like the right leg was dysfunctional. And so we ask them, did that make it easier or harder to perform that movement? If it made it easier or harder, that's leading us to the diagnosis of SI joint pain. And then we turn the patient onto their stomach. So SI joint pain is pretty specific, meaning if I feel that dimple, that dimple that everybody has in their lower back, that's actually the beginning of the SI joint. It's called the Sacral Sulcus. If I palpate that region, put pressure there and ask, does that hurt? And they say yes, that's going to be more specific for SI joint dysfunction. And then we're going to check it. So we do a maneuver. We drop the leg off the table, and I apply pressure onto the inferior lateral angle of the sacrum, and just ask them, go ahead and lift your leg up and over onto the table. So go ahead and try that for me. Good. And there was a bit of a shift. So when that shift occurs, there really shouldn't be much motion, you can sit up now, occurring through the SI joint. It should be a really solid joint, but unfortunately, like with pregnancy, you release a hormone called relaxin. Relaxin goes to every ligament in your body, and unfortunately, the pelvis is greatly affected. Those ligaments in your SI joint are so big and strong, it generally doesn't, they don't tear, they don't rip, but they become insufficient. So the best way to start fixing the problem is have very, very strong glutes, and specifically glute medius. So I call that the out and back. So if you rotate out and back, it's the ice skating muscle. It's the muscle that requires that pushing off motion. And that's the muscle we were checking during that maneuver that we were doing. So we, first of all, teach exercises. We get the glute medius as strong as possible because it's the only other component there that will help stabilize the pelvis. The problem with that mechanism is the fact that the glute medius isn't necessarily intended to stabilize the SI joint. That's a ligamentous problem. So, in many cases, we end up doing regenerative injections, which has been shown to do a great deal of good. The regenerative injections may be in the form of platelet-rich plasma or bone marrow aspirate concentrate or stem cell solutions, which generally help resolve this problem, especially in the younger population.